The broadcast is now starting. All attendees are in listen-only mode.
Right. Hello, I'd like to welcome you all here tonight. Oh, I'm just seeing which way I have to go. I'm coming a bit close to you, Tony. I'd like to welcome you all here tonight to discuss with us the lipid management in primary care. We're particularly focusing on statins because we keep getting feedback that people are finding it really hard to persuade their patients to use statins, even when we know there's a significant benefit to prescribing statins. So we really want to deconstruct this and debate the issues that people are concerned about, so you feel more informed and able to then discuss the issues with your patients. I'd like to welcome tonight the pharmacists, the doctors and the practice nurses who've joined us. It's just great to have you all here. We've got 210 people here, despite the America's Cup wins, so that's pretty good. So tonight beside me we have Tony Scott. Tony's a cardiologist. He looks as young as he did 20 years ago, hasn't aged. Took him an hour and 40 minutes to get across the Auckland traffic to get to us tonight, so we're very grateful you persevered and came. I'm just going to run through quickly the, I cannot do it, but it would be great, wouldn't it, if I could enter. Like, how am I doing that? Here we go. Just quickly updating you with the Goodfellow Unit site again. The Goodfellow Unit site is just a wealth of information. They really are focusing on providing education for everybody in primary care. We have the gems that come out almost every 2 weeks, and these are quick, succinct updates on things that will change your clinical practice. So keep an eye out for those. If you want to receive these, you just need to sign in and we get these delivered to you. Podcasts, of course, for the hour and 40 minutes in traffic. Turn on your podcast and you'll learn the latest in a variety of different clinical issues that are coming through your door every day. E-learning is available, again, probably a little bit more in depth for some issues, but some great courses there, particularly around dementia, motor neurone disease, a whole lot of issues, so keep an eye on that. And of course we've got the Med Talks, which we are restarting very soon. These are 15-minute discussions between myself and a specialist around a topic that's really pertinent to general practice. These are short and succinct and supposed to give you an update of everything you need to know in the time it would take you to see a patient. So tonight it's a webinar. It means that we want you to interact and to ask us questions. If you want to ask a question, press the orange arrow, write your question down and just send it in and we will receive it. We're looking forward to it. I will edit and review all the questions and try and thread them through the talk so Tony can answer them for us. So I'll hand over at this stage to Tony Scott, our cardiologist for tonight.
Thank you. So I'm just going to run through some topics that have been picked, and we're going to either dive into them or move on depending on what people's interest is. We're going to finish up with some cases and some sort of practical guides on how to, I guess, present some of the information to our patients. So the first thing I've been asked to talk about was the variability amongst statins. So there's discussion, as you will see, about high potency therapies and high potency statins and low potency. So the highest potency statin that's available currently is rosuvastatin, not funded of course. It's about twice as potent as atorvastatin, which is the most potent funded statin that we have. Simvastatin is significantly less potent than atorvastatin, but it still fits in the high group. Amongst the low potency, the only relevant one in New Zealand really is pravastatin. Fluvastatin sits in there as well. We'll enlarge on that a little bit later on, but I think it's quite important because with higher potency comes a higher risk of side effects, either from muscle pain through myositis, through the effects on diabetes and so forth. The lower potency statins tend to be better tolerated, and some of them have a better drug interaction profile as well. So I think it is important to have in mind where these statins fit in this scale.
Just pausing for a moment, we've had a couple of questions coming in asking about the availability of this presentation following the talk. We put this up on the website and you'll be able to access all the slides and any apps that we want you to be able to access in the future. So they'll be available at the end of the talk. So just sit back and enjoy and listen really.
Okay. So in terms of the benefits of statin therapy, there is clearly a lot of data out there, a lot of studies have been done, and statins are rather unique in having been one of the few classes of drugs that virtually all, if not all, studies that have been done have shown benefit. This can be distilled down to this top line. For every 1 millimole reduction in LDL, there is about a 20 to 25% reduction in cardiovascular events and a 10% reduction in all-cause mortality. Now that makes statins unique amongst all current lipid-lowering therapy and probably against future therapies as well. Some of you may have heard of PCSK9 inhibitors. A recent large trial has just come out showing clinical benefit. These failed to show a benefit in mortality, although they did reduce cardiovascular events. So statins really are quite unique in this. Now this benefit has been demonstrated in virtually all age groups and all levels of LDL, so right across the risk spectrum. The risk reduction at a relative sense is similar in primary and secondary prevention, low, high risk men versus women, but it is a relative reduction. So in order to determine the absolute benefit for a patient, you really need to know what their absolute risk is to start off with. And the balance of absolute benefit and potential risks and problems, cost, patients' willingness to take medications, etc., have to be balanced against that absolute risk.
Just pausing there for a minute, we've had a question about simvastatin, and really, is it a potent statin or is it a moderate statin or is it actually a...
I'd think of it as a moderate statin, and
Right.
it is listed amongst the high potency, but in terms of dose equivalence, it's significantly less than atorvastatin. It's less than half of atorvastatin's potency and less again when we're compared to rosuvastatin. There was a more potent statin available previously in the US, which was withdrawn due to hepatic toxicity, but I don't think that's ever been available in New Zealand.
Right. How much does, so if you were thinking about an atorvastatin, what sort of LDL lowering would you expect to see with a potent atorvastatin?
40 to 60%, potentially. There's quite a lot of variability in responsiveness, but you'll see that sort of extended reduction. That's compared to the dietary modification of LDL, which at most is about 25%, and that's going from a very poor diet to an excellent diet. So it is a significant difference in terms of reduction.
Simvastatin, a moderate 30 to 50%?
Yeah, 30 to 40%, I would say, for simvastatin.
Right.
But it is quite variable, and the response is reverse exponential, if you like, and that once you start a statin, you get your biggest gain with the initial dose. Doubling dose reduces these level by about 7 to 10%. So going up in small increments doesn't make a lot of sense for most people. I tend to double when I increase statins. And you shouldn't be disheartened that you won't get a doubling of effect. It's, as I say, reverse exponential.
It's good that we're going on to side effects, and perhaps we can talk about that, about when you do double the dosage, how, is there an increase in side effects, and how quickly should we put people on statins, and how quickly should we raise the dose?
Yeah, I think the side effects are dose related, those that exist. I think the real problem with statins, as people will know, is that the rate of side effects far exceeds, in reality far seems to exceed what is demonstrated in the trials, and it's often very hard, specifically with non-specific side effects like fatigue, cognitive changes, aches and pains. It's very difficult to sort out whether or not that's the statin or not. But certainly if you have a genuine side effect, a genuine toxic effect, then it is dose related.
Right.
So moving on to muscle injury, statins do carry a definite small increased risk of muscle injury, defined as injury defined as an elevation in CK level combined with symptoms and pain. The risk is estimated at around 1 in 10,000 patients per year. The risk of rhabdomyolysis, which people will definitely be aware of, is much less common, 2 to 3 per 100,000 patients per year. And as people will know, there have been deaths from rhabdomyolysis when it's particularly severe, but the rate of that is well less than 1 in a million. In general, however, muscle injury does resolve with complete resolution on discontinuation, and usually muscle aches and pains that people have resolve over a week or two. The reference that I've included at the bottom is an old one, and there are more recent ones, but in terms of patients who have proven rhabdomyolysis, only 13% required hospitalization and all recovered completely. Routine monitoring really is not recommended with regard to CK, for example. I only really do a CK if a patient complains of pain. I think the other thing to think about is significant rhabdomyolysis may occur with very non-specific pain, sort of aches and pains, flu-like symptoms. So I advise patients, if they do get a flu-like illness, that they should actually see their doctor, see me, and have a CK drawn just to check that it's not elevated. Muscle pain itself is much more difficult, and a causal link between statins and muscle pain really has not been demonstrated. Observational studies, as I've noted, suggest a 10 to 25% rate of discomfort. However, all of the large trials, the randomized trials, have not shown any difference between placebo and active drug in terms of the rate of complications, of muscle pain rather. There have been many discussions, if you like, around why this may be the case, when many of our patients do complain of muscle aches and pains and are quite adamant that it's due to their statin. One of the issues has been the run-in phase of a trial where drug is used before the trial starts proper, and the postulation has been that patients who are going to experience muscle pain in the trials are actually censored out of the study group before the start of the trial. In actual fact, this probably doesn't explain the difference, because only about half of trials have a run-in phase, and most of these use placebo for the run-in. So it's really just a logistics trial, if you like, to check that a patient is able to take the medication, able to follow up and so forth. So very few have had active trial drug in the actual run-in phase. There is a lot more detail about that if people are interested. In terms of an approach to muscle pain, what I usually do is stop the drug for a week or two. In general, muscle pain should subside over a week to two's period, and then reach out to see if it comes back. One of the problems that I've found is that while many patients are prepared to stop the drug for a week or two to see if the pain resolves, I've had very few that have started it again, even if the pain hasn't resolved. So I think that's, if you have someone who you feel should be on a statin, I think that's something that is worth really sticking with to try and get people back on the drug once they're stopped. As people know, our patients are very keen to stop drugs.
So you did say earlier that perhaps it was dose related. So is there any advantage in perhaps just reducing the dose rather than stopping it?
It's so difficult to tell with these symptoms, which are so non-specific, that I like to try and make a definitive diagnosis straight off. So rather than reduce the dose to see what happens, I generally favour stopping it altogether to try and get an answer. I think if the pain subsides, then it's the time to go back to a low dose, and we can talk about strategies of how you get people back on or find the right dose for them in that sense, because I think that's important.
Well, let's explore those strategies. One of the issues that's coming through in the questions is around CoQ10.
Yeah.
Should we be advocating that patients are taking that supplement to reduce their risk of muscle aches?
Well, the problem with CoQ10 is that there really is no good evidence that it has any effect at all. There have been a number of observational trials that have suggested a benefit, but the well-conducted randomized trials have failed to show any benefit whatsoever. There was a particular trial that I referenced later on, which I can provide for people, where there was a comparison. Basically, in one of the larger trials, they selected patients who had experienced muscle pain, which they attributed to statins. It was in a placebo-controlled trial. They then looked at those that had pain on statin but not on placebo versus those that had pain on placebo and statin, or pain on placebo and not on statin. So they were selecting people who had genuine evidence of having pain related to the statin. And of the 30 to 40% of people who experienced pain, only about half of those did not experience it with placebo as well, or less than half. Of those patients, they then randomly assigned them to statin plus CoQ10 or statin plus placebo. There was no difference between the groups. And this is in a high quality enriched group of patients who, by all other means, you would suspect were genuinely experiencing pain. So, and this information, this data has been reproduced multiple times. So I think at the moment there is no evidence.
You were saying earlier that you didn't think there was any scientific evidence either, just...
Well, it's, yeah, exactly. It's based on the idea that when you measure serum levels of CoQ10 in patients who have statin, then the serum levels drop. One of the problems is that CoQ10 is transported with LDL, so anything that drops LDL will drop CoQ10 levels. So it's a bit of an elaborate laboratory anomaly, if you like.
Right.
The other problem is that CoQ10, as people know, is active in the cells. So what happens in the serum doesn't necessarily relate to what happens in the cells. So if you, in the studies that have been done, animal studies, looking at the actual muscle tissue, there is not a change in the actual CoQ10 levels. I guess my personal approach is that if people want to take CoQ10 and they feel better, and it means that they take their statin, then I'm happy for them to do that. They tend to be expensive, however. But I certainly don't advocate for it.
Right. Carrying on.
So,
just about, you said, how do we restart them? You said that when you stop it, to stop the muscle pain, that it was hard to restart it again. What are your strategies around restarting a statin?
I think if we've established that the patient has whatever the symptoms are, muscle pain, I'm not myself, I can't think properly, whatever the symptoms are, I like to establish that it is related to the statin. So stop the statin, wait 1 to 2, 3 weeks, symptoms go away, then if possible, I like to re-challenge with the same dose again to make sure that they didn't just have a transient illness or something or other else, to see if the symptoms come back again. If they do, then, if you like, we've made that diagnosis that they have a side effect related to the statin. Then, if they're prepared to do it, I will start reintroducing. So what I would then do, if someone had significant problems, would be to start with a low-potency statin like pravastatin at a low dose. Start off at the minimum dose and see if they will tolerate that when it's reintroduced. If they have mild side effects, then I may just try an alternative statin. If most of my population is secondary prevention, so the people that I really do want them to be on a statin. So in that group, I will often say, well, let's try a different high-potency statin. For example, rosuvastatin if they're prepared to pay for it, simvastatin if they're not, but at a lower dose. But to basically try and find something that the patient finds acceptable in the form of a statin. And then once they can tolerate that dose, then I'll move up. Now, there will be some people that tolerate a low-potency statin twice a week. And my philosophy would be, well, that's still better than no statin. And if you look at their LDL levels, their LDL levels will be reduced even by that. And
that's quite an innovative way to do it, you know, is to be much more flexible about the dosing regimen so that we are actually taking patients with us rather than just prescribing and letting them walk out the door.
Yeah, I think
not collect the script.
Yeah, I think that's very important, especially if there's someone who has a lot to gain from the statin.
Right.
Hepatic toxicity is another difficult area. The transaminitis that people note or is described with statins occurs in only a small proportion of patients, maybe 3 or 4% of people, and by that I mean a mild elevation. I mean less than 3 times the upper limit of normal. The overall risk of hepatic injury is really quite low. and the risk of fulminant hepatic failure is extremely rare, 1 in a million. As I've listed in the slides there, in those with statin-induced injury, the complication rate is relatively low, although deaths have been reported. If the rise in enzymes is greater than 3 times the upper limit of normal, I think it's probably important to stop, wait till things recover, and then re-challenge. Now, there's quite a lot of debate in this area, and there is evidence that a lot of these rises that occur, although they may be related to the statin, don't indicate long-term injury, and often they will just go away again. The absolute cutoff is difficult and ranges between 3 and 10 times normal. But I think most international guidelines seem to talk about 3 times the upper limit of normal currently. All seem to agree now that there is no real value in ongoing surveillance or monitoring of LFTs in patients routinely are on statins. But again, the higher potency statins are more likely to cause problems if you have problems. Older patients, other drugs, fibrates in particular, when added, can increase the risk of hepatic toxicity.
Just thinking about the side effects, and we're told, should patients be taking the statin medication only in the evenings, or are they allowed to take it in the morning if they keep forgetting it in the evening?
I mean, we made a big deal of this in the past with taking statins at night. There are various explanations for this, and I'm sure some of the pharmacists online will be able to, will have opinions on that. But in general, again, if the statin is being taken every day but only in the morning, I'd rather that be done than take it intermittently at night. And certainly the lipid lowering effect is seen. I think it's much less relevant with atorvastatin. My understanding was that it was more of an issue with simvastatin. Certainly with Crest or rosuvastatin and atorvastatin, it doesn't seem to be much of an issue, as much of an issue. Diabetes is the other area of growing concern, if you like, amongst people. This was something that was initially thought to be, if you like, an aberration in a trial rather than something real, because it didn't make a lot of sense initially. But it is a real phenomenon. Unfortunately, genetic studies suggest that it is the genetic determinant of susceptibility to development of diabetes on statins is intimately related to the active site in the drug and the active site of effect. So it's very unlikely that we will be able to design a synthetic statin that does not have this effect. The rate is quite low in the trials, 10 to 20 patients per 10,000 patients per year for high-intensity statins, by which I mean 4 to 80 milligrams of atorvastatin or 20 to 40 milligrams of rosuvastatin. However, that has to be balanced against the beneficial effects. So in secondary prevention populations, 200 major events prevented per 10,000 as opposed to 10 to 20 new cases of diabetes. And in primary prevention, 100 events prevented per 10,000. So quite a different, virtually 10 times.
One of the concerns, I guess, for a GP is that they're not only looking at macrovascular disease, they're also looking at microvascular disease, and we're worried about their eyes and their kidneys. And what is the situation with microvascular disease with the statins?
There is actually evidence that statins can be beneficial for the microvascular disease in established diabetes. There are trials, or there is a particular trial looking at the use of statins in patients with established diabetic nephropathy. And in that population, the statin actually reduced the proteinuria, so presumably improved the microvascular disease. So the whole issue of development of diabetes is a little bit fraught in that sense, because you're looking at moving a person along a continuum from your pre-diabetic to frank diabetic, from your normal to pre-diabetic. So it really does depend on what your initial risk is. And when you look at the trials, the patients in the trials, the large trials, who developed diabetes supposedly because of the statin, small number of patients, they actually did a lot better. Those patients that remained on the statin did much better than those that didn't. Those that remained on statin had 45% fewer events than the diabetics who did not take the statin.
So it's a tricky one, isn't it? Because it is a worry. So what you're saying is that we are, by taking a statin, at risk of moving people along the diabetic spectrum, that those numbers seem to be quite small, and if they continue to take a statin, their outcomes will be better anyway.
Yes. And I think this is where the potency of the statins comes in again as well, because we know for rosuvastatin, for example, the relative risk increase of developing diabetes is about 25%. So a high dose rosuvastatin increases the likelihood that you will develop diabetes over and above your pre-existing risk by 25%. So if you had a risk of developing diabetes of 5% based on your obesity, family history, and all the rest of it, then the addition of rosuvastatin would increase that to 6.5%, for example. If you're using a low potency statin like pravastatin, then the risk is very much less. I can't remember the actual number, but it's more like around 1 or 2% over and above, so a much lower risk.
Right. I'm just looking at some of these questions. We've got a lot flowing in. I've got someone, Suzanne Rocket, telling us that diabetic nephropathy, there's a lot of evidence that it improves, statins improve it. I'm going to do a really bit of a backward thing here around, we missed out a lot about liver disease. Should we come back to that after diabetes, perhaps?
Yep.
So we continue with diabetes, and then we'll come back to some of the questions around liver disease that have flowed in.
Okay. So as I think I've already alluded, the risk of the development of diabetes is dependent on pre-existing diabetic risks, so obesity, metabolic syndrome, fasting glucose levels, and the data that I alluded to before was from the Jupiter trial, where those developing diabetes on a statin who continued their statin had a 45% lower risk than those who developed diabetes but did not remain on the statin. Overall risk was similar in the entire trial and again, just emphasising the risk reduction is greatest in high-risk patients such as those with diabetes, despite any increased risk of developing diabetes.
Going back a little bit to those hepatotoxicity, we are really struggling in general practice with so many of our clients having abnormal liver function tests, fatty livers. Should we be concerned about starting these people on a statin?
The evidence suggests probably not. I mean, it does make it challenging if you've got quite wildly deranged LFTs, but the evidence suggests that in those that have deranged LFTs, mildly deranged LFTs, that they're not at greater risk by starting a statin. Again, there is some evidence that fatty liver may be reduced by pravastatin. One trial that I came across that showed that. But it is challenging, I agree. And certainly that's the prevalence is going to increase in all likelihood, unfortunately. I did not see any evidence that statins worsened that situation, I have to say.
Right. Great. Okay. Monitoring, just again, do we need to do liver function tests and monitor them while a person's on a statin?
Recommendation is now not to do that. So I think if someone has, including not doing a baseline LFT level, I have to say that's something that I have done not infrequently, but I don't do it routinely. Usually, however, it's different for me because I usually have access to LFTs in most of my patients when I see them. So, but there's not the recommendation currently.
Right.
So the other issue that's very topical, particularly on talkback, is memory and cognitive dysfunction. The FDA put out a statement a couple of years ago stating that there was an association. This was not based on robust data, I have to say. But the more in-depth data, looking at large trials, has really failed to show that association. There is quite a big difference between observational data and randomized data in this area. The systematic review that I've mentioned there from the Mayo Clinic proceedings talked of a systematic review and meta-analysis of 16 studies, 23,000 patients, no association of statin use with incident dementia development, and in fact a reduction of dementia development in the high-quality cohort studies that were looked at in patients receiving statins. The presumption would be that was by reducing microinfarction, multi-infarct dementia. patterns by the vascular effects of the statin. If you look at the randomized data, however, and that comes, for example, from the HPS trial, 20,000 patients, and then combine that with another large trial of around 6,000 patients, though these trials were not designed to actually look at the development of dementia or otherwise, these two trials did actually measure cognitive function, and they did not show any difference, either positive or negative, between those patients randomized to statins and those not. And you're talking about a large chunk of patients, a large population. So the evidence of decline in memory and cognitive function is really not there.
That's actually really reassuring, because in the lay press that's a big issue for us. One of the GPs has asked about lipophilic versus hydrophilic medications being absorbed into the brain.
Yeah.
Is there any issue around this with statins?
Well, there are differences in their absorption, and some. Yes, I off the top of my head, I can't really go into great detail, I have to say, but there are differences in absorption.
Right. So if you were concerned about that, maybe would that be worth us looking at, or no particular evidence to support?
There isn't evidence to show any difference. I mean, to show an effect, and so it's well worth postulating. But when there's no evidence that there is any effect from any of them, it makes it more challenging.
I'm going to ask you about fatigue, because some patients will just tell me they just feel awful when they start a statin. I'm just so exhausted. Is there any evidence around generalised fatigue in statins?
Again, no, there isn't. But anybody who prescribes statins has had that experience with their patients who say it, and they feel much better when they stopped. And I have to say that I'm the same. If I have a patient who's complaining bitterly of fatigue, then I will withdraw the statin, as I will withdraw other medications. But the general theme that comes out again and again with in the trials and the reviews is that if someone is developing symptoms like that, cognitive changes, memory changes, fatigue, then we shouldn't jump to blame the statin. We should look at other medications. We should look at other things that are going on with them to see if there's something else that's being masked. And for that reason, I think a withdrawal trial of statins is quite useful, because in my experience, most often it makes no difference.
I've got a great challenge here from Ranu Tamraka about the duration of the trials. And most of them are under 5 years. So are we actually just not seeing the effects that people are concerned about because the trials are too short?
It's a very valid criticism, and I don't have an answer to it. Yes, many of the trials are ongoing, and data tends to come out as they proceed. One of the problems is that trials that we're dealing with now that have been going for some time won't have had predefined outcomes or predefined analysis points around cognitive change or fatigue. They'll be around vascular endpoints and hard endpoints. That's the issue with the HPS trial. Very rich source of information, large population of patients, but we didn't have
designed to look at
those endpoints, and that can be a problem. But it is a valid point.
Well, that's a good point. We're just getting some questions about a little bit more about primary prevention, when to start statins, how to start them. All of that's going to come up in the talk. We're going to talk about primary prevention, we're going to talk about secondary prevention, and we're going to talk about particularly prescribing in the elderly and stopping prescribing. So all of those issues will come up as the talk evolves. At the moment, we're focused a lot on the side effects, because what we want you to be is informed around the real evidence, so you can discuss this with your patients.
Very much so. And I think the other issue is, well, just in support of that, there is a lot of information out there, a lot of trial data which is not included in this talk, but if people are interested in it or do want it, I can make that available to people if they want, in terms of some of the high quality data that is around there. The other issue that has been raised intermittently over the years is the issue of hemorrhagic stroke, and there is evidence that there is an increased risk of hemorrhagic stroke due to the statin, 1 to 2 cases per 10,000 per year. There has not been evidence, however, that there is any increased mortality associated with stroke for those patients that are on statins. And overall, there is a net benefit in terms of first or recurrent stroke with the use of statins. I suspect because the actual hemorrhagic stroke is much less common than that due to vascular atheroma. So just moving back to general principles of statin use, I think I would start off with the general principle that if indicated, if we come to the decision that the statin is indicated for a particular patient, then any statin is better than no statin. And if their need is great, secondary prevention for example, then the general recommendation is for the maximum tolerated dose of statin before adding anything else or doing anything else. Now that of course comes in addition to all of the other strategies that we have in terms of risk reduction, dietary modification, exercise, blood pressure control, everything else. In general, in someone who requires statin therapy, I would start with atorvastatin as a potent statin. If there is a risk of or previous experience of intolerance, then you can be particularly if you have a patient who's a bit sceptical, then I would start with something that's more likely to give you success, i.e. low dose pravastatin as a low potency statin, and then move up as you need.
If we have patients on simvastatin, should we be moving them to atorvastatin?
Depends on the patient really and the dose. If you've got a patient on 80 milligrams of simvastatin, then I would move them to atorvastatin, because there is evidence that does significantly increase the risk of side effects when compared to an equivalent dose of atorvastatin. So I would not use 80 milligrams of simvastatin anymore. If I had a patient who was tolerating simvastatin who was in a secondary prevention group, then I would try and get them on atorvastatin or a more potent statin to increase that. If we're talking primary prevention and they're happy and their lipids look reasonable, then I would leave them on simvastatin. Alternate day dosing, even down to 1 to 2 times a week, there is evidence that that's beneficial for patients if that's all they can tolerate. And as we talked about before, withdrawal and reintroduction trials. Monitoring is, as I've alluded to before, still a difficult area. I do tend to monitor for effect. So once I've started the statin, I'm testing a lipid profile a month later, just to see what sort of effect we've had. But, you know, part of that, particularly in primary prevention, is so your patient can see beneficial effects. They can see some achievement in terms of what they're getting. In terms of toxicity, if there is a suspicion for toxicity or a high risk of toxicity, then I would at least check once. In terms of routine monitoring, that's still potentially an issue as not being required unless there's a
we're talking liver function tests and we're talking
CK and so forth.
Just going back to the effect, we're tending to focus a little bit more on LDLs as to look at the benefit that we're wanting to see. How low should we go?
Well, again, it depends on the risk of the patient to start with, because there is evidence that any lowering to any level, down to quite low levels now, provides additional benefit.
How's quite low?
Well, quite low now is well below 1.
Oh, I'm feeling distressed.
So that, you know, the PCSK9 inhibitors will drop people's blood LDL levels to sort of 0.5.
Really?
0.4, 0.5. And there is evidence from Fourier trial that's beneficial, even going down, even taking someone from a level of 1.5 down to 1. There's pre-existing evidence that is beneficial.
For primary as well as secondary prevention?
Across the board, but the problem is that in primary prevention, the absolute risk is so low, is already very low when you have levels as low as that your absolute gain is quite small.
Right.
And I think it's very valid to set a starting point, set a starting goal of where you start, what level of risk you start off with, because there will be a gain across the board, but it's relatively very small in terms of absolute benefit.
I have to say, I have tended to stick to 1.7 for secondary prevention and under 2 for primary prevention. Is that still acceptable, or am I too relaxed?
1.7 is what I tend to use for secondary prevention. I would be more relaxed for primary, and again, it would depend on the person and in terms of what their risk was for primary prevention. If they had a coronary disease equivalent risk, then I'd be aiming for below 2.6, but that's sort of the old level if you were doing that. Now the current American guidelines, for example, don't look at a level at all. If you're looking at secondary prevention, it's maximum tolerated dose. So I tend to move more towards that. And some would say they don't even bother measuring the LDL anymore or the lipids anymore. They go for maximum tolerated dose.
See any evidence that that statins affect the HDL? Which ones are the most beneficial on HDL, and does it actually improve outcome?
That's a fraught area for some people. I think becoming possibly less fraught. The trial evidence suggests that most statins increase HDL a little. As far as I'm aware, there is no data that shows that makes any difference to risk. We know that low HDL correlates with high risk and high correlates with low, so long as it's not too high. There is no evidence that changing the HDL makes any difference, and there is evidence that it causes harm depending on the drug you use. It's a class of drugs called the CETP inhibitors that double the HDL, significantly increase mortality, whereas there is abundant evidence that lowering LDL reduces risk.
So the focus is on LDL,
very much
not on HDL.
Yeah. I mean, I use the HDL and I get worried about it if it's low, but I look at that as a pre-existing risk indicator, a lifestyle indicator, if you like. If it improves, then people are doing the right things in their lifestyle, and possibly the drug helps.
The tricky thing is that the Heart Foundation is still using the ratio to assess level of risk. But when we move to treatment, we move away from the ratio to LDL. Am I right?
Yeah, that's the guideline, but it's a unique guideline to us here, I have to say.
Okay. So there is debate about that. I had one question. If you are changing someone from a simvastatin 80 milligrams, you'd drop it for the atorvastatin, you'd reduce the dosage to 40? Or?
Yeah, I would go from 80 simvastatin to 40 atorvastatin would be my step. Yeah.
Is there any evidence of pancreatitis being affected by statins?
I don't know the evidence, I have to say. I haven't encountered that. I've encountered a lot of unusual side effects and pericarditis and various other things and serositis. So presumably there could be, I mean, any drug can cause pancreatitis, but I'm not aware of a specific
Alcohol's probably much more common.
I would say so, yes.
Okay. Let's just keep moving now, and we'll bring in more questions as we go.
We've got to our cases. First case is primary prevention. Woman of 56 years, no previous history. We don't know about her family history. She has an HbA1c of 45, so not diabetic, but definitely solidly pre-diabetic. She's a little overweight, but not obese, 29.8 BMI. Total cholesterol approximately 7.5, LDL of 4.6, HDL of 1.3. Blood pressure is in a normal range. So now I think you had recalculated her risk, but initially we looked at a risk of around 10 to 15%, and the total cholesterol being just below, if you like, an absolute treatment threshold for cholesterol is an isolated risk factor of 8, which is, I have to say, is not one that I use, but
yeah, this is the thing that gets us in primary care, is that you've given this number of 8 and then you suddenly jump to high risk, so you have to treat them. But you've got a lot of people tinkering along at 7.8 to 7.9, and that's why I wanted to bring this to the table. Let's talk about that. I mean, it really is arbitrary, isn't it?
That is very arbitrary, and I think it comes from the LDL risk of 5. So many international guidelines recommend treating an LDL over 5 as an absolute single risk factor, and it comes from the whole issue of familial hypercholesterolemia, genetic abnormalities. But even that has become a lot more complex recently. We know that if someone has true familial hypercholesterolemia, not combined familial, which is also inherited, but it's multigenic. If you have a single gene abnormality resulting in an FH, then you will have a high, when you're a heterozygous, then you'll have a very high LDL, sort of between 5 and 10. And your risk is between 12 and 25 times somebody who just has that LDL but doesn't have the gene. So it's a very high risk patient population. There is a tendency to look at patients with high LDLs and say this is FH. In actual fact, a recent study that published last year, and Jack showed that only of adults with an LDL over 5, only 2% had genetically proven FH. So
familial hyperlipidemia.
So if you make that, there are a whole series of criteria you can use to make that diagnosis, most from clinical through, you can actually do the gene test easily enough now. But I think that's where that idea comes from. I do tend to recommend statins for patients with LDLs over 5, I have to say, regardless of their other risk factors.
It's interesting, and that's something that we can hold on to. Because in fact we had that question about starting statins for primary prevention in 18-year-olds, and somebody at the beginning of the talk talked about someone with, I can't actually see it now, but somebody with a cholesterol, I think, of 7.9 at 18 years. I mean, when should we start these statins if they're people with high cholesterol?
If I go back to the previous example of the previous study, this study showed that if you looked at, rather than adults, if you looked at children with an LDL over 5, then 50% were abnormal genetically. And so you're looking at now a patient population with a very, very high risk who benefit enormously from statins.
And so we're talking about starting them in their 20s.
Or teens.
In teens.
And younger, if it's very high. I mean, I think that patient population should be looked at very closely because
they probably require specialist review.
I think they do require a specialist review, and possibly, I mean, I might offend some people, possibly also a genetic review.
Yeah.
In that case.
Is that genetic testing available in New Zealand?
It is.
It is available through a specialist.
Well, I've ordered it. I don't know if it's restricted. I didn't receive any pushback, so. I think you can order it. I wouldn't. It's an expensive test to send away. It takes 4 months to get a result because it's batched. So it's not something you would do readily. And I have only done it when it was going to have a definite impact on a patient's outcome. In this particular case, it was when there was compassionate availability of a PCSK9 inhibitor for those who were gene positive, but they had to be gene positive.
Right.
So I wouldn't do it otherwise.
So the question is that if you've got an LDL over 5, to start thinking about a statin for primary prevention, but we're aware that that's an arbitrary number. Let's just go back to this woman of ours who's got a cholesterol of 7.8 total cholesterol. Let's go through, because one of the issues is the absolute risk is much lower in primary prevention. So let's talk through how we work with patients and with primary prevention.
Well, I think I do like the idea of looking at absolute risk. It's something that started in New Zealand 10, 15 years ago at a time when no other guidelines did that. Now virtually all other guidelines do this and look at absolute risk, because that's where, that's in those with high risk, that's where you get the gains. So I think I would do that with this particular patient. Now she's below the 15% sort of threshold that we look at in New Zealand. In terms of 5-year risk. She is about at the level that the American guidelines, for example, use. They use 7.5%, but that's a 10-year risk rather than a 5-year risk, so it's probably similar. And they then recommend drug treatment at that point, in addition to lifestyle and everything else. I think she's just a little below that. For me, the turning point, I mean, clearly she would have aggressive lifestyle modification or attempts to do that. But to me, the tipping point would be her family history. If she had a very bad family history, then I would strongly encourage her to take a statin at this stage. If she had a very good family history, then I would be less inclined to go for the statin and more inclined to just do the lifestyle things.
Got the issue coming through around, should we be more proactive with Pacific people and Māori who have these sorts of levels? Is there a concern there?
There is a concern that the risk is higher, that the onset of disease tends to be 10 years earlier. And I think that does factor into the risk, some of the risk equations that we use in New Zealand. I think that is a good point.
What's the role of calcium scoring in primary prevention? We've got these risk factors, we're looking at them. Should we be doing calcium scoring?
I think that we probably should not be doing that routinely. It was being recommended for a time in the US, for example. It's no longer recommended. There's a high calcium score does indicate a high risk. We know that. The question is whether or not it adds anything to our other risk assessment, and the cost of it, etc., and what you end up with.
There was, I think one of the cardiologists at Rotorua was talking about calcium scoring. Is there any evidence that if you go on a statin you reduce your calcium score?
Well, you won't reduce it because calcium in the arteries is a reflection of disease activity. So if you imagine that you have an inflamed vascular system, and that as part of that inflammation, as in anywhere else in the body, calcium begins to be laid down. And some people would speculate that it is actually a reflection of micro-rupture and plaque erosion as well. So this reflects actual activity of atherosclerotic disease. So that calcium's not going to get removed. EDTA does not remove it in terms of chelation therapy and so forth.
Right.
So it won't go down. So sequential calcium scoring is probably of no value. Well, it's definitely of no value. There is argument about initial risk assessment, but universal agreement that it shouldn't be sequential.
Let's go back to perhaps the apps that we use in general practice.
Yep.
And I'm actually going to step in here a little bit. This is Bruce Arrell's favourite app, and it's from the Canadians, and it enables the clinician to discuss the potential benefits of treatment for primary prevention. So I'm going to attempt to put this up. I'm not great at this, but my colleague beside me is. Where is it, my friend?
That's it. Back one. Keep going.
No.
This one. Next one.
That's the New Zealand one.
We'll bring that up and then we can change it over.
Okay.
So at the top.
So I'm sorry, I'm just the best not at doing this. Okay, this is a Canadian app, and I've actually started using this in my general practice recently. Took me a while to master the circles, but what we've got here is an ability to assess the person's level of risk along here, and you add more, family history is included. But what it enables you to do is to say, what is the likely benefit if I give you physical activity? So with this person, who is our primary prevention lady, we do know that the total number of events in 10 years is likely to be about 8%, so 8 per 100 women, exactly the same, will have an event in the next 10 years. And if I get them actually physically active, I'll be able to lower that by 3. Is that right?
Yep. 2.9%.
2.9% reduction. Then you can actually show them what a statin will do as well. So it gives them the opportunity to look with you about the size of the benefits. Now, I think I've only started playing with this. I'm not particularly confident with it yet, but I have found it fascinating. And if you do, you can also look at diet versus medication, and you can look at different medications. So you can look at ezetimibe versus a statin versus a fibrate. So it actually gives patients more information to make that decision on. So this is a site that we will actually show you later. We all know about the heart forecast tool that is in our within the PMSs that we're using. I do use this product a lot in general practice, really to trigger action usually. Normally people are saying to me, oh, but I'm pretty average. And my thoughts are, no, you're not that average. So I use the tool. But the weakness of this tool is that we have no ability to show them the benefits of different interventions. But it does give people a call to action, really, to say, actually, my risk is at a level which I think I need to do something about it. So we've got both of these products available for us, and I really was keen for you to see that so that you can play with those within your own general practices. So it's not clear with primary prevention, is it? It's a lot harder than the black and white secondary prevention.
It is.
The more tools you can use, perhaps the better.
I think so, and I think it's the one comment I would make on this, and we were talking about this before, is the Canadian tool is very nice. However, it doesn't show you the additive effect. So it will show that the effect of exercise is only slightly inferior to the effect of statins in terms of 10-year reduction of risk.
But the combination gives you the added benefit of both, and I think that's important. But when you're looking at the magnitude of the effect, I think it is helpful.
It makes it very visual to demonstrate for people.
And remember that there is a new tool coming out in New Zealand, which I think we will be able to manipulate, like the Canadian tool, which is really exciting.
Yeah.
So keeping on, moving on, that's just the New Zealand guidelines, that's the guidelines that you're all using. So in synopsis, your primary prevention.
Well, I mean, my goal is to, I mean, the stated goal of, I think, the guidelines, the Heart Foundation guidelines, was to reduce risk by one category when you moved into the different areas. I mean, to my mind, you want to reduce risk as much as you can, and I think my primary prevention goal would be to, in someone who doesn't have a bad family history and is at very high risk to start off with, would be to reduce their LDL into the normal range, if you like, so below 3.4, if there is a normal range. If they have a bad family history, if they're diabetic, by bad family history I mean conventional bad family history, so premature, father with an infarct, 55 or less, brother with an infarct, 55 or less, mother, female relative, first degree relatives, 65 or less. In those patients I would go to the old level of 2.6 or lower in terms of primary prevention. But again, what we want to do is the goals are changing all the time. The average cholesterol in New Zealand in 1965 was about 8. It's much less than that now.
Total cholesterol 5.6?
It's about 5.6 now. The risk of dying of a heart attack in New Zealand now is 10% of what it was in 1967. And only the last 20 years of that has anything to do with us in terms of medicines. The rest is a whole raft of other issues. So, you know, it's general quality of lifestyle improvement, if you like, that we want.
Let's keep moving, just being aware we've got 15 minutes left, and we're going to move on now into secondary prevention.
So a Maori man in his 60s had an MI 3 years earlier. Lipids prior to treatment, total cholesterol of 6.2, LDL 4.8. After treatment, total cholesterol 4.9, LDL 3.5. And what is the evidence? So in this patient population, I would be striving for, if we're to use a target, and there is, as we've said, there is debate about whether you use a target or a therapy goal. But if the target I would be going for his LDL is 1.7, and I would be working quite hard to get him to that. Many guidelines now talk about maximum tolerated statin, which is generally what I will do. If this patient was in hospital with an MI, we would attempt to send him home on maximum dose of statin. So that's what he would come back to your practice on.
We find that a bit of a challenge because they come back on very, very high dosages. And then my patients say, I've got all these side effects, that's it, I'm out of here. And I've always taken the lean mean approach, which is to start low and build them up and to keep encouraging sticking with the drug. But we do get them out of the hospital on very high dosages.
And one of the issues there is there's quite good evidence that very early high-dose statin provides immediate benefit.
So I'm harming my patients by the low-slow approach.
If you start off that way, what I guess what I'm saying is they have still gained if they are on that high-dose statin for the first 2 or 3 weeks after their infarct, as opposed to not being on it and then starting and building up. Now, so if they come out of hospital on this and after 3 weeks they decide I've had enough of this, I'm stopping, then what I would like to see is them go back to the previous approach of saying, okay, well, let's drop back. Let's prove that your side effects are coming from the statin. Now let's try and get you back and find out what your maximum tolerated dose is. I don't think you've lost something if they're so burnt by the experience that they never want to take it again. Then you've lost. But if they drop down and then come back up and end up on 20 milligrams of atorvastatin, then there is evidence that they have gained benefit from that initial period on high dose.
Well, that's very interesting
so
for us.
I think that's the approach I would have with that, and I sympathise for. You know, the hospital docs don't live in the community; they live in an acute environment where things are changing and so forth. So it's what happens when that patient goes out into the community from then on that then makes the difference.
But it is really important for us, I guess, to affirm you and to say, you know, the reasons you put you on this very high dose is we know that that's going to give you maximum benefit. So, you know, what they've done is really helped you through that first transition post-MI.
Yeah. And unfortunately, there are many things that have changed in recent years in terms of our approach to acute coronary syndromes. I mean, immediate revascularization has made a huge difference to outcomes. Statins have made a big difference. And it's quite difficult to tease out the relative effects of all of these things quite often, especially when you start looking at old data. And old data is maybe only 5 or 10 years old now. The rate of change.
It's just so massive. So that's great. So we're much more aggressive and supportive of patients on higher dosages with secondary prevention, aiming for an LDL of about 1.7. Right. What happens about this gentleman who loves his grapefruit and his marmalade for breakfast? Am I worried about that with him on a nice atorvastatin?
There is an issue. Clearly there's an issue with interaction, and that will increase the risk of toxic effects, but simply by elevating the level.
Oh, so it pushes it up?
Pushes the level of the statin up.
Even with marmalade?
Marmalade, I don't know. Depends how it's made. If it's grapefruit marmalade, certainly.
So it will. It is.
I suspect it does. I mean, again, the pharmacists out there might be able to help us. But
okay, so we've still got a bit of a grapefruit anxiety going on, and it's appropriate.
I think it is appropriate, but I don't swear people off grapefruit completely, I have to say. But if they're a daily user of grapefruit, then that could be an issue.
Right.
But again, it's probably a dose effect too, in that sense.
So I think we've covered that. Everything we wanted to do. We've got lovely Michael Hammond, a pharmacist, speaking out for us. Yes, avoid grapefruit marmalade. Nice to hear your perspective. I want to talk a little bit towards the end now about the elderly. This is a real problem for us in general practice because it's not just the starting of the medication, it's when we can ease off the medication, because a lot of our older patients are wanting to stop medications. Let's talk through the older patient.
This is a problem area. It's not just with statins, it's with all of our therapies because of the way our studies have been designed and the populations of the studies that the patients that we're looking at. And there has not been, in the past, there was not a lot of evidence. There is a lot more evidence now in the over 75s. We know that the coronary risk goes up dramatically as people age, and once you're over 70, your most important risk factor is your age rather than just about anything else. So in terms of absolute risk, if there is a reduction of risk proportionally, then their absolute risk starts off very high, so their absolute benefit is high. And the evidence does support that concept. And some of the larger trials have had a reasonable number of elderly patients in them, and the elderly patients contribute disproportionately to the endpoints as well, so they are the ones having the acute coronary syndromes. So they do gain benefit. And the trial that I've listed here, pravastatin 40 milligrams in 70 to 82-year-olds, high vascular risk or established vascular disease, and they benefited significantly, 15% relative risk reduction in the primary endpoint, which was acute vascular events, 19% reduction in coronary events, 24% reduction in coronary deaths, no effect on stroke or cognition, but TIAs were reduced by 25%. So a definite benefit, and that's using a low dose, relatively low dose statin. And again, there is trial data suggesting that there was a higher benefit with high dose, high intensity statin as well. And in this particular synopsis of studies, the safety profile was very similar. A bit of a typo there. Myocardial ischemia reduced in both, that's my typo. And significant reduction in cholesterol and all-cause mortality, and a trend towards reduction in major cardiovascular events in the atorvastatin compared to the pravastatin group. Again, HPS, one of the largest trials ever conducted, 20,000 patients. 28% of those patients were over 70. And while they haven't been dissected out as a subgroup, they contribute to the overall population. In Jupiter, again, a reasonably large trial with relatively low cholesterols to start with, 32% over 70, but they accrue nearly half of the endpoints. So they were significant. So the
older are at greater risk.
They're at greater risk.
They are going to get benefit.
They are going to get benefit. They're also at higher risk for the hard side effects as well. So I think caution does have to be exercised, and again, I have a lot of trouble pushing a 90-year-old to take statins when they're quite happy they've got to where they are. And certainly if someone has got to ripe old age without an event, then they've already self-selected to some extent.
I have to say that has been my policy, and I've got a lot of 80-year-olds that are running in cholesterols between 6 and 8.
Total cholesterol.
Total cholesterols. And I have tended to believe that if they're over 80, they've done pretty well with it.
Yeah. But
do I need to intervene?
Well, having said that, that's, in a way, that's the same approach that our predecessors had in the 60s and 70s with 65-year-olds.
So we should be more aggressive, you're saying?
I suspect, while they have self-selected by getting to that age, that, as we say, they do gain benefit. And virtually all of the average age of my patients now in hospital is about 75.
Yeah.
So
is there any evidence that with the older patient, if they've been on it for greater than 5 years, that if you stop the statin, that the benefit still lasts for another 2 years or so?
I don't know that data. I mean, it could well be there.
Right.
I mean, the benefit of statins is in reducing acute events rather than preventing atheroma forming. So
it's an anti-inflammatory component.
It's the well, we don't really understand. I mean, I must admit I'm not a believer in the simple LDL hypothesis. There is a definite reduction in events. I mean, that was the primary finding of the early trials. The early trials were designed to look at reducing atheroma formation. They failed. They did not reduce atheroma formation. They just stopped having MIs.
Right. So there is a multiple...
It's a pleiotropic effect. There's multiple effects at multiple levels, I believe. Okay. So, again, goals of treatment, I think, to my mind, the same thing applies with the humanistic side in terms of all the other things that are at play in the elderly in terms of their medications. So I would still use the same goals and the same maximums. I have to say I treat my elderly patients the same as everybody else.
And when we're stopping a statin, how do we stop a statin?
I don't see any reason why you should wait. Well, it depends why you're stopping it, I guess. If you're stopping it because someone is attributing a side effect to it, obviously, then
just stop it.
I would stop it, test it, and reintroduce it. If you're dealing with someone who's on multiple medications and the real problem is polypharmacy and what they're doing, then I have to say I would be looking at other things to stop before the statin. But if you're going to stop it, then just stop it. It's not like stopping a beta blocker where you have to wean them off.
Fantastic.
From that standpoint.
Just going to talk a little bit about other products now on the market. And we've had a lot of questions about whether we should be using a statin with a fibrate or a statin with ezetimibe. Should we be using combinations or just pushing the statin up?
I would say the general principle is maximum statin first, because that, as I've said, the statins are the only drugs that have this mortality benefit. Other drugs, really other drugs don't have the mortality benefit. Some of them will reduce effect. So we know we give our patients the maximum benefit by giving them the maximum dose of tolerated statin. I think we have to be cautious about adding fibrates, particularly gemfibrozole. We should not do it. The risk of myositis goes up significantly, and the other risks of toxicity go up for arguable benefit. There may not be any benefit at all. Now that is different with ezetimibe. If you'd asked me this 5 years ago, I would have said ezetimibe's probably going to disappear because it had been around for a long time and there was no evidence of clinical benefit. A lot of evidence of clear reduction, quite dramatic reduction in LDL in many patients when you add ezetimibe to their statin. But it wasn't until the Improver trial came out a couple of years ago that we were able to demonstrate any actual benefit from it, clinical benefit from it. So as it stands at the moment, the only combination that I would see as having evidence behind it would be ezetimibe added to maximum dose statin. Right. Now, we have a slight problem, I guess, in that it's only funded if the LDL is still above 2, but there is evidence the Improver trial that the levels they were going to were much lower, and then they were taking their patients down to convert in my head to a level of 50, which is about 1.4 or 1.5 or something, from about 1.8 or 2 down to 1.5, and those patients gained benefit. It's relatively small, but they did gain benefit.
We've had a few questions around triglycerides. Tell me a little bit about triglycerides. Should we be treating these? What do statins do to triglycerides?
Torvastatin in particular may lower triglycerides, and presumably rosuvastatin can as well. It's really hard to dissect triglycerides out as an independent risk factor. They go hand in hand with low HDL, and if you stratify out the HDL, the power of the triglycerides as a risk predictor is much less. What I use triglycerides for is what I refer to as a metabolic policeman.
Yes, I agree.
So it's a lifestyle policeman. If someone's triglycerides are improving, then I know they're doing something positive with regard to their diet and exercise levels and weight levels. Very sensitive to that.
Alcohol? Significant impact on it.
I think alcohol does too. I mean, high triglycerides are bad for other reasons, don't get me wrong, but I think they're not my primary focus.
If you're going back to the IMPROVE trial with ezetimibe, that was secondary prevention. Is there any role for us using high-dose statins and ezetimibe in primary prevention?
I'm not aware of data on that, I have to say. I probably wouldn't be doing it. Unless, well, someone would have to have it wouldn't be front line, I have to say. And as I say, I'm not aware of data on that. And I don't know that we will get data on it, to be honest. It's taken 12 years to get secondary prevention data.
Okay, just finishing with the last slide.
Other alternatives. Again, fibrates do have an effect on LDL. Their clinical benefit is pretty small, and some people, many people have moved away from them. I've virtually never prescribed them now, I have to say. Niacin also has favourable biochemical effects, particularly on HDL and maybe some triglyceride as well. But again, outcome data is not so good anymore, and it's no longer really recommended. The only new drug that's showing a clinical benefit is the PCSK9 inhibitors.
Are they available in New Zealand yet?
Not available, funded in New Zealand at this stage. They're very expensive, so I don't know if they will be in the near future.
Just keep our eye on the horizon.
And yeah, I think to me it's an avenue to pursue in terms of a therapeutic approach. I like the idea of a PCSK9 vaccine rather than an injection, if that's ever possible. So I think there are selected patients for whom there will be benefit, and with the FURIA trial there is now good outcome data showing the benefit as well, and it's the first new class to show that really in about 20 years. So.
Well, it's been a fantastic night to overview statins, where all of us out there are facing issues, discussing these with our patients, and I want to thank you, Tony, for taking time to spend with us. I want to thank you all for signing in and for sharing your questions. I think it's been an invaluable night for us as primary care clinicians, pharmacists and nurses. So thank you very much for signing in, and at this stage we will close the webinar. Thank you very much.